Hi, I want to welcome you to the webinar, What We Know and Don't Yet Know About DCIS. I'm Deb Hackenberry. I'm the Program Project Manager at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization. It's been helping people through breast, ovarian, and uterine cancer for the last 45 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to the participants. For more information, please visit our website at sharecancersupport.org. All the participants are going to be muted during the presentation. When Deborah finishes presenting, we will begin the Q&A discussion. You're welcome to submit questions during the presentation through the Q&A section at the bottom of your screen. The chat section will be disabled. When asking questions, remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and it will be available on the SHARE website very soon. Now I'd like to introduce our speaker. Deborah Collier has been a leader in patient engagement and advocacy since her first cancer diagnosis. She utilizes her business leadership, IT, and communication skills to bridge research gaps between scientists, medical providers, and patients. Deborah founded the Patient Advocates in Research International Network in 1996, where research meets reality and consults with the health and medical research communities. Deborah has infused hundreds of patient advocates into research programs while creating a variety of trainings and delivering innovative ways to gather input from thousands of patients. Her work encompasses many diseases, programs, and policies at grassroots, national and international levels, and emphasizes patient issues throughout early development and protocol requirements, recruitment, retention, and results reporting. Deborah also serves as consultant to health literacy media in their Clearly Communicating Clinical Trials program. I know I'd like to welcome Deborah.
Thank you, Deb. I know having the same name is a little different here. I want to make sure you can see my slides. Are those working? Yes?
I believe so.
So thank you everyone for joining. We're going to have an interesting discussion. First, I'm going to give a little bit of information and then we should have time for questions as well to talk about DCIS and what we know and what we don't. And of course, I'm going to do a couple polls and we'll find out how many of you have DCIS, but it's a confusing world and there are lots of reasons for that. And I'm going to go into some of them. Of course, to me, the most important person is the person facing DCIS. In case you didn't know, I am a 2-time breast cancer survivor. The second one was surrounded by DCIS. So I do know a little bit about something personally, as well as in the work that I've been doing and working on a couple different research grants within DCIS itself. But, you know, as a person is facing a diagnosis, there are doctors that you work with who diagnose, and sometimes that's radiologists, sometimes it's surgeons, sometimes it's someone else. Then there are doctors who treat, which can be surgeons, radiologists, or medical oncologists. There's all sorts of different kinds of research that's going on, for everything from basic research to clinical research to epidemiology, which gives us population science and risk factors, and also health delivery research into healthcare and how do we do a better job delivering care to people. And then, of course, everything is based on the regulations that companies are allowed to do in their research, policies, and then a final product of some type that may be developed. A lot of times that can be devices for surgery, or that can be drugs and can be other things as well. Part of the problem is that we act like DCIS is all one thing, but it isn't. And I actually looked, and I've got references in most of the information here. There are at least 75 different breast diseases, quote unquote, or conditions that can be listed. And in the slide presentation, they're actually listed. And a lot of misinformation is thrown around, sometimes in medical practices themselves, sometimes through the internet and through social media. So what we're going to try to do is talk about what people want to know, what you want to know, and where we are in research right now. So there are lots of different opinions. And I know these are questions that I get all the time from people is, why are there so many opinions? Why do some doctors say I need surgery immediately, or I need surgery and radiation, or maybe even hormonal treatment? And then some say, well, you might not need it, any surgery, any kind of treatment, active treatment right away. Is DCIS cancer or not? There's still debates about that you probably know. Is it going to come back? And if so, would I die? What should I expect? What is risk? That's a very difficult concept to get your head around. And so we need to talk about that. And also, why, if this isn't cancer or isn't something for me to worry about, why am I being referred to cancer doctors most of the time? So that's something that the system is set up with the people who know most about cancer, even though not all DCIS will ever advance to that. And the real question is, why is this so hard? So I don't know if we'll get into that. I don't know that I'll be able to answer that one, but we certainly will be talking about it. But first, we've got a poll question for you. And Steph, I hope you've got the poll ready. I wanted to know what sounds better to you. There's 6 different definitions here of what could be called DCIS. So I just wanted to know what one makes the most sense to you. So Steph, are we doing the poll? I don't know. Oh, there's something in the Q&A. Hold on. Yes, okay. So I'll wait just another couple seconds here, and then we can show the results. Okay, doesn't look like it was set up. Sorry about that. So as you probably already know, DCIS wasn't really a major thing in breast diagnoses and conditions before 1980. And that's when mammography started to really increase. So that's when DCIS diagnoses also increased quite a bit. So the question is, does that matter? Does that, does that mean that more women are having breast cancer? And there have been several studies, and they all kind of show the same thing. What I'm showing here is a study from the University of Oslo that showed that screening resulted in more breast cancer being found. It resulted in more DCIS being found, but there were no changes overall. And so what that actually means is, in the overall death rate, is that there can actually be overtreatment being done with DCIS, and they estimated about 3 in 10 women might be overtreated, where in fact they didn't even need surgery or anything. There have actually been studies in after autopsy of women's breasts that show that there was either DCIS or even breast cancer there that was undetected, but they didn't die of that. They died of something else. So there is a theory, and actually some research is proving out, that we all have some cells running around in our body that could be cancer cells. Most of the time, the body takes care of it, but sometimes it starts growing uncontrollably, and that's when it can turn into cancer. So, oops, excuse me a minute. Let's see, that works. So when we talk about the different kinds of breast conditions, why is DCIS treated differently? And you see here, we've got LCIS, which is lobular carcinoma in situ, sclerosing adenosis, Atypical ductal hyperplasia, ADH is what it's normally called. You may have heard of that as well. And then DCIS. The two conditions that have cancer cells identified inside of them are the two on the ends, LCIS and DCIS. So the others aren't. And so that's why they're called, uh, they're treated more as cancer because there are cancer cells. But here's the thing that's weird about the whole thing. There is not a cutoff between ADH and DCIS. So it's a matter of preference or that person's interpretation, the doctor that's looking at those cells, between whether or not it's ADH or DCIS. Both have, actually all of these, especially LCIS as well, have a higher risk of developing breast cancer at some point in a woman's life. And yet none of the others are treated quite the same way. They don't treat LCIS, they just watch for it, active monitoring. ADH sometimes gets surgery and sometimes doesn't. And yet with DCIS, to date, almost all women have been treated with surgery at least, and then sometimes beyond. So it's really more of how the whole culture grew up. And unfortunately, I don't think we can do this poll question either, because I wanted to know what kind of DCIS you may have had, if you had any at all. So we'll go over that maybe in the discussion period. So what is DCIS? And it really does depend. It's not one thing. It's not one kind of a breast condition that is a precursor to cancer or non-invasive breast cancer or anything like that. It's a breast condition. Sometimes it is at higher risk than others. So as you can see here on this side, this is a grade 1 DCIS. There are grade 2s and grade 3s. It's actually important to know the grade of your DCIS, because as you go down the scale, grade 1 is a fairly low risk. It's very slow growing. The cells look normal to abnormal compared to a normal breast, which I'll show you in just a minute, to a higher risk, which is still not high risk, but is higher than grade 1. So grade 3 looks a little bit more has different size and shapes of cells in it. And so that's when they get more concerned, and everyone agrees that women with grade 3 DCIS should be treated. The question is still out on grade 1 and 2. And as you can see here in this other picture down here, these are still considered grade 1, grade 2, and grade 3. They can also be called low grade, intermediate grade, and high grade. And the fact is, you see how different they look, and yet they're still classified in the same classification. And that's because there really are no set guidelines of this is what is called a grade 1, grade 2, grade 3. There are some guidelines, but they aren't actual rules, as Barbosa would say in Pirates of the Caribbean. So when you're talking about DCIS, that's one reason why so many of us suggest that you get a second opinion if there's any doubt. If it's clearly low grade or clearly high grade, that's fine. But of course, most DCIS falls somewhere in between. So it's like 80% of DCIS could be grade 2-ish, grade 1-2, or grade 2-3, and nobody's really clear. So the most important doctor you may never meet is called a pathologist. And pathologists are the ones who diagnose conditions that can include DCIS, can include breast cancer, and the other kinds of conditions. But it's not always easy to diagnose, and different doctors have different opinions about what that might look like. So getting a second or even more, I have a plus sign there because sometimes other opinions can be really important. Now, as you can see, I have the same picture there from the grades 1, 2, and 3, but you see what normal looks like. And you can see that, obviously pathologists are trained and spend lots of time on diagnosing and testing out different things to make sure that they do their own research on cells to make sure that they can be as accurate as possible. But it's kind of in the eye of the beholder. So we'll talk about that later when you guys have a chance to talk to me too. When we talk about DCIS, of course, the main issue and concern for everyone involved is, what is my risk of getting invasive breast cancer? And a 10-year risk, in a big review that happened in 2019, this is with a group that I've been working with in the Netherlands, found that in reviewing lots and lots of research papers, they came up with this list of risks to invasive breast cancer that actually kind of stand the test of time and have been looked at with good evidence applied to them. So if you find DCIS by touch, by feel, instead of by mammograms, that can be an indication of a higher risk. If the margins when they're cutting out the DCIS are not clear, in other words, they can't get a clear rim around the edges, that might be an issue. If you are still having periods and you're considered premenopausal and you have DCIS, that can lead to a higher risk. These are, by the way, in order of risk. So this is the top one, then down the list. Unfortunately, if you are an African American or have African ancestry, that can be a higher risk. High grade, the grade 3 that we talked about, having a level of P16. Now, that is not a marker that is normally checked on DCIS, but that can be one, and that's what researchers have found. And then if you have less access to the medical system, there can also be a higher risk. I just want to emphasize that for grade 3, I think most everyone is in agreement that treatment is useful there, because that is potentially has a higher risk of having a 10-year risk of invasive breast cancer. If that is the case for grade 3, high grade DCIS, there are a couple of tests that you may have taken or you may have heard of or might not have heard of. Right now, the two on the market, at least in the US, and I believe globally is available as well, are called Oncotype DX and DCIS RT. It's really Decision RT. There are some differences between these tests, so I wanted to just at least briefly cover that. The Oncotype DX test was based on clinical trials that were done with women who had DCIS and invasive breast cancer. So it's not DCIS only. And they looked at only the tumor, the lesion itself of DCIS, not anything in the surrounding tissue. It can predict a 10-year risk of recurrence and give you the benefits or risks of radiation therapy. Decision RT is a little bit different because they're looking at not only the tumor or the lesion itself, but also the stroma, which is the surrounding cells that support that cell and communicate back and forth between it and the rest of the body. So that has different markers and different levels of risk that can be predicted. And they have actually predicted in studies an individual's risk of 10-year recurrence. That's a little bit different than in the clinical trial, which covers kind of an average of the thousands of women that were in that study. And then they can also predict the individual benefit of radiation therapy. And they have actually been able to reclassify DCIS up to about 50%. So what that means is when a pathologist looked at it and graded the DCIS and the size of it, their test has actually seemed to be more accurate with what's going to happen in the future sometimes than what a pathologist can see under a microscope. So now we're going to move on to low risk DCIS. And Dr. McIntosh, I think, did a very good job of stating what you'll hear often from people is, and I'm going to read this quote to you. It's generally low and intermediate grades, which are grades 1 and 2, are considered to be low risk, with the lowest chance of becoming invasive cancer or of having some type of DCIS recurrence. There is increasing scientific evidence that low-risk DCIS grows slowly and if left untreated would not cause health problems during a woman's lifetime. So that's something to keep in mind. And again, we're separating out the types of risk here. And I mentioned grades 1 and 2 as being part of low risk. Also, ER or PR positive, HER2 negative, and if you're postmenopausal, meaning roughly 50 years old or older, are considered lower risk factors for DCIS to become anything else. So if you don't treat DCIS, there are a couple slides I'm going to show from some research here. And as you can see here, this is for low grade DCIS. The one line is surgery and one line is women who had no surgery. Now, this was after the fact. They looked at what happened to women, the outcomes or the results of women who were treated for DCIS or who did not get surgery for DCIS. And they found out that the 10-year survival rate was basically the same, as you can see here, over 98, almost 99% in both cases. So it's not a disease that you have to worry about dying from. So what about what happens afterwards? Another study looked at over 1,200 patients who had DCIS without any type of treatment, with an average of 60 years old, which is about the average age of a person with DCIS, although you can certainly be younger or older. With a follow-up of 5.5 years, you can see here that there was about a 12% chance of grade 1 and 2s getting invasive breast cancer in the same breast. That's what ipsilateral means, over a 10-year period. But for grade 3, it was a little bit higher, about 18% over a 10-year period if you had grade 3. So you see that while it's a higher risk, it's still not super high. It's less than 1 in 5 women that will go on to have invasive breast cancer if they have grade 3. Again, another study, and this was done what's called prospectively, which means this study was done while women were enrolled in the study. So these were clinical trial participants. And you can see here the difference between high grade and low grade in their risk factor of getting additional DCIS or invasive breast cancer. So there's quite a difference in the level of risk that someone has. But as we said, it's still low overall compared to some other women. And in fact, what happens is there was a study that was done that showed that women who were treated for DCIS, so got at least surgery, had a slightly lower risk of all-cause mortality, meaning when they died, the women who had DCIS actually had a little lower risk of dying than women just in the general population. So it's not an emergency. There really isn't a right answer. You do have time to decide, and treatment is really more a personal preference, not only for the person involved, the woman or man who has DCIS, but also, frankly, the preference of the doctors that they go to and what those doctors are saying to them. So if a doctor feels more comfortable with surgery, they're going to suggest surgery. If they feel that radiation is really important, they're going to mention that as well. So it really is more of a personal preference. And as you can see there, I have at the bottom of the list active monitoring someday for some patients with DCIS. The next question is, does delaying treatment matter? And there are varying degrees of answers here from different studies. The most recent one that you might have heard of is a newer study that was done just this last year that seemed to feel that there was a slight higher increase in invasive breast cancer over time And that means from women who were diagnosed to surgery, who had surgery in less than 30 days, all the way up to 120 days, which is 4 months later. There was a little bit of a higher risk. The problem with the study and most studies is that they did not review it at all by the grade of DCIS that those women had in that study. So they were lumping all DCIS in together. And they didn't really check on any of the known risk factors that we know about that I've already mentioned to you, but are listed here as well. So it's really hard to compare notes and know whether there is a higher risk or not, depending on the risk factors of the individual women who are in that study. So we're hoping that that will become more the norm, where they're actually looking at grade and other risk factors in the studies that are being done. So we're going to talk about some of that research now that's going on right now for low risk DCIS. I'm not going to be talking about high grade. There is a science project, and I am involved in this one, that's going on that's looking at the biology of the breast and DCIS and what's happening there. And they're looking at it in many different ways, as you can see here on the poster, to hopefully identify the type of DCIS that will remain DCIS, won't become anything else, and those that might develop into breast cancer, because that's really important to find out who's at risk and who really needs treatment and who might not need it, at least right away. There is a randomized clinical trial called COMET in the US. I'm also a patient advocate involved in that study along with others. And what we're trying to do there is, I'll be talking more about COMET, so I'll explain more, but finding out about the difference between, if there is any difference between active monitoring when you're first diagnosed with DCIS versus getting surgery. And so that trial is ongoing. There are no results from it yet, but it's a very important study. And then there are other studies in different parts of the world that are going on to try to learn the same thing. So the good news is they're all talking together and connected together. So when we get results from these ongoing studies, there should be a lot of good information. And part of the research that's going on is to try to identify more risk factors and help with decision guides and aids so that people with DCIS have a better idea of what their choices are and then can decide what's right for them. I'm going to talk very briefly about Precision, which is the research grant I talked to you about. It's actually funded by the Cancer Research UK, CRUK is what it's called, and it's called DCIS Precision. And that stands for Prevent Ductal Carcinoma in Situ Invasive Overtreatment Now. So what they're doing is they're taking samples from patients, which are very important, patients that have donated tissue samples and have agreed to have their clinical data in there and be followed over time so that we know what's actually happening with real, in this case, women. And then they're looking at it from lots of different aspects. They're basically looking at the biology of the DCIS itself and looking at ways that we can identify different markers through DNA and RNA, through the microenvironment, which is the stroma I talked about that surrounds the tumor itself, through imaging. Are there ways that we can see what's happening more through imaging? So it could even be non-invasive detection. Animal models are being used with human samples to see what happens, as well as what spatial genomics means is basically like 3D. What's happening all around the breast, not just on a flat slide under a microscope. So that can be important. And then they're trying to integrate all of that information together and use data from the trials that I mentioned as well, so that we can come up with better ways to separate out the groups who would be at higher risk versus those that aren't, and then what could be done with them. So that's what that diagram is all about. As far as clues that we've learned so far, as I mentioned, the samples are very, very important. And there are about 50,000 women samples that have been collected with their tissue and their data on DCIS. And that includes 3 different countries right now, although there are 2 additional countries that we're hoping to get samples for and be able to study along with this at one time. As you can see, there's a very wide time frame involved. These samples are started in 1999 and actually go on until today, but the samples that they're looking at right now go through 2015 and have at least 5 years, and many have 10-year follow-up information now. So it's a really rich group of samples to be looking at that can tell us a lot. And so these are the samples that are being used in all of those different biology ways to try to see what makes sense. What we have learned through precision and other sources now is that grade does actually matter. There are about half of DCIS is grade 3, and about half is grade 1 and 2 combined, which would be considered low risk. Now that depends on the country. So you see here, there's kind of a wide range of percentages, anywhere from 8% of DCIS in one of these samples was grade 1 to 16%. So that kind of gives you an idea. Breast conserving surgery is done most of the time in all of the countries. Radiation therapy is done often. That happens more in the US and in the UK. And hormone therapy, some countries don't do hormone therapy at all. In the US, we do a lot, so it can be up to 54%, and that's if you're ER positive or PR positive. But there is no difference in survival or in outcome, which is really interesting, or even in the percentage of women who are getting DCIS or invasive cancer. Another thing that we've learned from the precision study is that if we're looking at DCIS to a future DCIS within 5 to 10 years, it's about 2% of women in these cohorts or these data sets that got another DCIS in a 10-year period. So as you can see, that's pretty low. And then the question becomes, is that residual? In other words, is that just because there might have been some cells left over and they weren't found originally and they happen, or is it a recurrence? Meaning, is it an additional DCIS that's tied to the first one? If it's in the other breast, by the way, which is called contralateral, that means the other one, then it's considered to be a brand new DCIS. It's not considered to be connected at all to the first one. And that doesn't happen very often either. If we look at DCIS to invasive breast cancer within a 10-year period, about 2 to 3% of women did get DCIS to invasive. Now, in these samples, that does include grade 3. So again, they haven't ferreted all of that out yet. We're hoping that that will be done by the end of the grant so that we can make sure that that's reported on. What they did find that was really new and unusual and unexpected is that at least 20%, 1 in 5 of those DCISs that turned into invasive cancer were not related to the first cancer. So 80% of them were related, but 20% were not, which means it could be a totally different reason for getting that invasive breast cancer. So that's really important, and I'm sure it will be debated a lot, but they were very careful with that analysis, and they double checked it and they validated it within these different data sets of DCIS that I talked about. And that's a very important part of research, is that they validate their work. So we know whether it was just a fluke or whether there's actually something to it that they need to dig into more. So other findings, unfortunately, they haven't found any other risk factors yet, and that includes lifestyle factors. So there are a few things that that kind of seem like they might be risk factors, but they weren't done in a way that shows us clearly that they were. Pathologists definitely grade DCIS differently. I mentioned that before, but there's a study of all three of those countries, and there were 3 pathologists from each country that looked at the very same samples. And they agreed with each other, I think it was about 20 to 30% of the time, but they didn't agree the rest of the time. So up to 70 or 80% of the time, there is disagreement or different ways that they diagnose. So we're looking into that and how can that change. There are similar risk factors with women who get DCIS surgery or women who don't. The size of the fat cells within the breast, when it's combined with something called COX-2, may affect risk, but that has not been validated yet and needs to be before it would be available in the clinic. And different growth patterns of DCIS may impact risk. So they found some that just kind of replace what was there, and they find others that look like it's growing. And so they're looking into those clues to see if they can come up with some different risk factors for that. And they also have found some animal models that really seem to mimic human DCIS, which is important because in order to learn what's happening in the biology before something is actually done in humans, we need to know what it is. So what's happening next is that they're adding more samples, as I mentioned. I believe Norway and Australia have data sets that they're willing to join together with this group. We're going to bring all of the information that they're finding in the different projects together and hopefully start to build a risk model. So that's precision. What I'm going to do now is talk just briefly about some of the trials. As you can see, there are the 3 trials that are going on, or studies that are going on. LORIS is in the UK, LORD is in the Netherlands and Europe, and COMET is in the US. LORIS and LORD started off as randomized trials, but they have not, LORIS is closed now. The LORD study has become more of a patient preference study. And so what they're doing is looking at the difference between standard treatment, which is considered surgery with or without radiation, versus active monitoring or surveillance. And they're followed with annual mammography. So if anything changes, the person would certainly be treated. I'm going to talk a little bit more about COMET because it is the only randomized trial right now that can gather the type of evidence that we need to be able to say which women really need treatment and which women may be able to go with active monitoring at the beginning and wait until they may actually need treatment. So COMET stands for comparing an operation to monitoring, which means active monitoring, with or without endocrine therapy. So you don't have to have hormonal therapy for low risk DCIS. So comparing surgery to active monitoring. And I think I will go on because I'm not sure where we are on time, but I'm sure I'm talking too much. We're trying to understand the risks and benefits of each of the approaches and find out if one could be recommended to some patients and which patients who have low risk DCIS. Just to give you an idea, there are additional studies that are going on in the COMET trial, and that includes different imaging studies and what can be done to do better imaging, and patient samples. The blood and tissue are being collected there as well, so that the women in all 3 of these studies can also be looked at when comparing notes with what the precision study is learning, for example. And this just gives you an idea of the way some of the language is being used. We're trying to approach it in a very balanced way to explain what surgery is, what active monitoring is, and what it means. And that includes the advantages and disadvantages for both arms. So for surgery, what some of the advantages are, what some of the disadvantages are. And I'm going to just kind of breeze through this. I'm sorry, I'll be happy to do it, but I want to make sure we have time for questions. Also, the advantages and disadvantages of active monitoring. So you can see that it avoids some things, but there could be more anxiety. It also means that there may be, you know, future surgery when needed. Words matter. And so as part of the patient leadership team of the COMET study, we've tried to make suggestions to the clinicians, right? The providers, healthcare providers that are doing this study, instead of treating DCIS as a single condition, for example, explaining that there are different kinds of DCIS that have different levels of risk. It's not well understood. You know, instead of using all of the cancer words for it, like it's a pre-invasive cancer, talking about it in different ways. So often everybody hears about it as if it is cancer and they're treated as if it is cancer. And so it's no wonder that women are worried about it progressing to invasive breast cancer. But for at least 85% of women, 80 to 85% of low risk women will never have another breast event. So that's important to know. This just gives you an idea of decision support. There's a tool that's been worked on through with Dana-Farber and University of Utah that is available so that you can go through this and decide what type of treatment options might be right for you. And the Netherlands Cancer Institute, which is a part of the Precision study, is looking at developing a decision tool as well. So the good news is there will be more information when these clinical trials are done and when the Precision study is done. I have some websites you can stay tuned with. And if you have DCIS or you get DCIS, remember there's plenty of time to be making a decision that is right for you. And there are trade-offs between what your future risk might be versus what the treatment effects are today. So decision tools, we hope, can become very handy. And communication is really important. So I'd like to thank you with that. I do have some resources at the end, but it's time for us to do Q&A if we still have some time.
Deborah, I want to thank you for a great presentation. And yes, let's start the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We'll try to get through all of the submitted questions, but we may not be able to due to time constraints. So let's go to the Q&A.
Okay, and I'm going to stop sharing so they can see us.
Okay.
Okay, but I did want to also say I do have a page of resources here, and the presentation will be shared afterwards, so you'll have that information.
Okay. I'm going to start with these over here. Does the level of risk of patients with the BRCA1 mutation make a difference?
It does, and I would say that purposely patients or people with BRCA1 and 2, for example, and genetic markers were not a part of these studies. So they're involved in Precision, but we don't know the rates. And they're not in like the COMET study. That's actually not an eligibility criteria for the studies because there is a different level of risk there. It's a little bit higher. I'm sorry, I don't remember the exact amount. I don't know, Deb, if you know that offhand.
No, I don't.
Okay. And I did not include any references for that. I'm sorry. I can do that, or you can, you know, there are good organizations like SHARE and FORCE and things like that that can give you, I think, better indications of information with genetic risk.
What are the timelines of these various studies? That is, when do they expect them to end? When do you expect to be able to get the results from them?
Okay, that's a really good question. So the Precision study will be done, the Precision study will be done next year. So toward the end of 2022. There are some publications that are starting to come out with it, like the one I mentioned about 20% of DCIS is not related to a new invasive breast cancer. That paper is has been submitted and is being reviewed right now. So hopefully that will be out later this year. But that study is over by the end of next year. The COMET study will stop enrolling patients mid-year next year. So like June of 2022, I think. And then we still have to wait for results. So it'll still be a couple years after that. And I think the same thing applies to the other international studies I mentioned.
Does a large area of DCIS require mastectomy? This person was told if it was over 5 centimeters, she had to have a mastectomy. But she's read in many places that this is only if it will take a lot of the breast, that is a cosmetic rather than a medical choice. So does size really determine if there needs to be a mastectomy?
Right, does size matter? It's really, there's some studies that seem to indicate yes and some that indicate no, unfortunately, because a lot of the studies aren't done with the power, with the amount of data that are needed, or aren't studied quite as stringently as some of these that I've been talking about. So do you have to have a mastectomy? I would say most doctors would probably say no. Many of them would feel more comfortable the bigger it is. However, if you think about it, a lot of breast cancer, invasive breast cancers, get breast conserving surgery. So I'm not so sure. I would probably get a second opinion, at least before I made a decision about what type of surgery to have. The other thing to remember is that breast conserving surgery, or lumpectomy, whatever it's called, can take a sizable amount of the breast. It can take up to 30% of the breast area. So that is something to consider, depending on how deep it is, whether it's by the surface, all of that matters. So I don't give medical advice, but I would suggest that you get another opinion before you make a decision.
Was the 2% recurrence rate for DCIS related to treatment or grade?
The 2%, well, I had listed those out separately. So there's a 2% for low risk, right, of getting another DCIS. There was a 2 to 3% 10-year risk for getting invasive breast cancer. And that is the grade 3 level. So that's the higher grade DCIS.
Are there efforts to standardize guidelines for pathologists to reduce wide variation in findings?
There are, and I've been told, and I'm learning more and more about that every day. It's very difficult because as I showed you, there are different samples that you can look at that can look really different, but they're kind of graded in the same area. So there are some criteria for each of those grades. It's not like there's nothing that they don't look at, but we're actually working on that. And there's the College of American Pathologists, and I think they put out some guidelines, but it really ends up being what that pathologist's preference is. How conservative are they? If they're more conservative, they're going to go toward the higher grade more often than not. And so, for instance, in the UK, they require 2, I believe, or 3 pathologists to look at the slides themselves. And then if there's any disagreement, they grade it up just because. That doesn't seem to make a difference on survival, though. So, or additional, future breast cancer or DCIS events compared to the other countries.
Are there new imaging protocols that are promising?
Yes, but it's not ready for prime time yet. So there, for instance, there's something called crystallography, and they're looking at like the metabolism in the body and in those cells, and trying to identify like heat ranges, right, within them. Or are there some that are at higher risk because of these factors or those? So they're actually discovering some new things that hopefully will be able to come to the clinic in the next 5 to 10 years, but it's not ready yet.
Is that different from thermography?
It's similar, but it is different. Yeah. There, and then the spatial side of things, the 3D elements are really starting to, they're starting to make some discoveries in that area. So I think we'll see more of that type of thing in the future as well, which is good because that will be able to represent more of the real breast, right? And the whole breast, not just a slice of it.
If invasive breast cancer was found during a biopsy and only DCIS was found during the subsequent lumpectomy, is the remaining DCIS more likely to become invasive breast cancer in the future than the DCIS in women who haven't had any invasive breast cancer?
Okay, I think I understand that question. If you have any type of invasive breast cancer, whether it's on the biopsy or a later surgery, it's considered stage 1 breast cancer. Okay, if there any type of invasive breast cancer, it's considered breast cancer, whether or not DCIS was there. And in my personal experience, my second breast cancer was that way. I had an invasive breast cancer surrounded by DCIS, and that was considered invasive breast cancer. That's how we're going to treat it. That's how we're going to consider it. So in a subsequent surgery, if it's only DCIS, I don't know the answer to that. I don't know that anybody knows the answer to that as to whether or not it would become invasive breast cancer. And again, that's because we don't know enough about where that comes from. One thing I will say, and I don't know that I actually mentioned this before, is that the ducts, milk ducts, that's where DCIS and invasive ductal carcinoma comes from. Okay. So the milk duct isn't in just one location, right? It's like a tree. It goes back and forth. So what they're trying to also find out is if there's a difference in where that cancer might be in the future. Was it in the same duct? If it was, the current thought is, without a lot of evidence to back it up, is that that's probably from the same vein almost, right? It's like the same milk duct, they'd have the same conditions within that whole milk duct versus another milk duct that's in that same breast. I don't know, is that confusing? Probably. So in other words, nobody knows. That's the answer to that question.
In breast cancer conserving surgery, is survival contingent? Oh, this just jumped. Is survival contingent on radiation and mastectomy? Wait.
Right. Okay. I understand the question. Okay. I think I do. If you have surgery versus no surgery, there doesn't seem to be much different in overall survival. If you have radiation therapy on top of that, there could be a slight increase in survival, but really it's more about whether or not you get a future DCIS or invasive breast cancer with radiation instead of survival. Does that make sense? So if you have surgery and radiation, you probably have lowered your risk of getting another DCIS or an invasive breast cancer, but it doesn't necessarily change overall survival very much at all.
Okay, so someone has asked, is tamoxifen the only hormone therapy for DCIS for estrogen receptor positive breast cancer?
No, it depends on the doctor and what their experience has been as well. And if you're postmenopausal, if you're not having periods anymore, there are other types of hormone therapy called aromatase inhibitors that are sometimes looked at. As far as tamoxifen, there's also raloxifene, and I'm not sure right now today how popular all of those other drugs may be. And it can depend on that person too, and your particular situation, health situation, age, all those other risk factors that we talked about. So there are other options besides just tamoxifen.
Are there any types of research being done regarding African American women or African women, since that's clearly one of the risk factors?
There is research being done, but I don't know of any study that's being done just in African American women. What we're trying to do is explain this as an issue and as a higher risk factor, and then talk about the research that's going on to try to make sure that we have women of all colors who are represented well in these clinical trials. And that's difficult because of the way that the system has been set up with, systemic racism, as well as mistrust in communities, well placed for lots of reasons. The thing I would say about these research studies are really well done. There is an ethical board that has looked at everything, more than one, in fact, throughout the course of the study. We're there as a patient leadership team involved in the study so that we're constantly bringing up patient issues and ideas. We really do need to figure out how to have better conversations and make sure that we get African American women and Latinas and women of color in these studies as well.
Someone has asked if have you heard of DIM hyphen Avail? How effective is this compared to the standard endocrine therapy?
I'm not up to date on that, so I'm going to say I don't know at this point.
Okay. What can women do if they want to take a larger role in improving cancer treatments, clinical trials, or basic science research?
That's a really good question. I think it's really important to work with groups like SHARE, who has a voice in some of the research. If you are interested in that and getting involved as a research patient advocate, which is really a very different type of patient advocacy than others are, there is training that you can go through for that. And I would be happy to talk with anybody about that and kind of point you in the right direction. There's not an easy path to it, I guess I would say, but there is a way to get involved if you want to.
Why does high grade get treated more like invasive than medium grade?
Okay, it's because there are more cells that look like cancer cells and are acting more like cancer cells. They're growing faster. There's more abnormal shapes and sizes of cells, which are kind of indicators of what happens with invasive breast cancer. So it's possible that they're getting to the point where they're ready to start. They're not ready to start, but they could break free of the duct. That's the main difference between DCIS, it stays in the duct, and invasive breast cancer, it breaks out of that duct and into other parts of the breast, like the fatty tissue and stuff.
Is endocrine therapy being offered as neoadjuvant treatment for DCIS or like some sort of treatment prior to surgery? If so, how successful is it? Does it shrink the lesion?
Okay, that's a good question. And I think it's being offered kind of in place of surgery sometimes. And I imagine there are some studies. I can't think of any off the top of my head, but I know that some people are looking into that. But there are really no results out yet about that. So I think they're thinking about it the way we think about neoadjuvant chemo for women with breast cancer, for example, which has been known to shrink tumors at time of surgery and things like that. So I don't know if that is a coming trend or not, but I do know that a lot of doctors suggest endocrine therapy instead of anything else, or endocrine therapy after surgery at this point.
Can a change in diet and exercise affect DCIS that is eliminated?
There hasn't been anything that shows that it eliminates it. So it's not like a treatment. But, you know, diet and exercise, as we all know, is a good thing to do. What I would say is, what I've seen too often is that women get scared and then they decide to like go overboard on all sorts of other things, whether it's diet, exercise, supplements, or what they've heard the latest on the internet and all of that. The main thing that I've learned through time, not only personally, but through thousands of women and talking with lots of doctors through time, is do what feels right for you. Don't go to extremes. You know, moderation in all things actually is a somewhat trite but true. Um, you know, if that makes you feel better, then do it. But don't expect that it's going to prevent or treat the DCIS.
Well, I think that this is a good place to end it. We're just about at 4 o'clock. I want to thank you, Deborah, for a wonderful and informative program. And thanks to all of our participants for submitting questions. We would like it if you could take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also be in the follow-up email. Thank you so much for attending. We really appreciate it. And thanks for sharing all of your knowledge about DCIS. It certainly is a confusing diagnosis. Thanks.
Thank you. I appreciate your time, and I hope the best of health for everyone.
Thank you. Bye-bye.